Hi everyone. So I'm gonna go over some of the hematological disorders. Please forgive me, I am a little sick. That's why it took me a little while to get this video across, but I'm feeling better, so I'm gonna get through this as quickly as I can. So the first thing that I want to talk about is polycythemia vera, which basically means that there's an excessive amount of erythrocytes or red blood cells, leukocytes or white blood cells, and thrombocytes or platelets. Okay, so we have a lot of those. And because we have especially a lot of these red blood cells, that means our blood is going to become really thick, or what we call hyperviscous. We're going to have really, really thick blood because of all of these circulating blood cells. So typically what we see in these patients is a hemoglobin greater than 18 in men and a hemoglobin greater than 16.5 in women. Because remember, average hemoglobin is 12 to 16, roughly. So anything greater than that, we're looking at potentially polycythemia vera. But I would know greater than 18 for men and greater than 16.5 for women, or whatever Dr. Remy has told you for these specifications. Also, a hematocrit greater than 55%, because normally normal hematocrit is like 35 to 50%. So we expect in these patients to have a hematocrit of greater than 55%. And this is because, like I said, polycythemia vera means that we have an excessive amount of red blood cells, white blood cells, and platelets. So the blood is becoming really thick, and that means that these patients are having problems with perfusion and they're having cyanosis, okay? So things that we expect to see in their assessments include in their skin, dark purple and cyanotic, because as we said, decreased perfusion due to the thickness of blood. Cardiovascular symptoms such as descended veins because of all that increased blood, which can cause intense itching. Hypertension because of the thickness of the blood. Thrombosis or clot formation because of the increased platelets. Poor gas exchange because of that thickness in the blood, and hypoxia because of the thickness in the blood. So we see a trend. For treatments for polycythemia vera, we have apheresis, which is basically you remove all of the blood, you remove all of those excess red blood cells, and you reinfuse them with new plasma. So you technically are taking out their blood, fixing it up, and putting it back in. We can also give anticoagulants so we can prevent those clots from forming, and we want to give them IV fluids. We want to hydrate them to help reduce the thickness and increase perfusion. Because remember, they're having poor perfusion because of the thickness of the blood, which is causing cyanosis. Then we have very important client education because, yes, MedSurg wants you to understand the pathophysiology of the diseases, but the most important thing is what am I going to do for my patient and what am I going to teach my patient? So the main goal is to prevent clots because they can get, remember, increased thrombocytes or platelets. So we want to really be careful for clots. So we want them to drink at least 3 liters of liquid a day. We want to have them avoid tight or constrictive clothing. This is because the tighter the clothing gets, the more likely a clot can form. And remember, hydration is always good for preventing clot formation. Wearing gloves when you're outdoors in those cold temperatures because all that vasoconstriction can lead to even more poor perfusion and they're already cyanotic. Wear compression stockings. Now, compression stockings aren't like tight restrictive clothing. They actually help promote circulation the same way that the DVT boots, those ones, they also help with preventing clots. So that's the mechanism of compression stockings. They don't necessarily mean like tight clothing, but they actually help promote blood flow. We want to elevate any sort of feeds they might be getting when they're seated. We want them not to smoke because smoking will increase clot formation. And if this is so important, even if it's not about polycythemia vera, but in any exam, if a patient has chest pain, they must stop what they're doing and rest. Okay, so especially in this case where they might have a clot formation or a risk for a pulmonary embolism, we want them to stop activity at the first sign of chest pain. The next thing that I want to go over is anemia. Anemia means we have a reduction of those number of erythrocytes or RBCs, right? So hematocrit, hemoglobin, things like that. And there's a bunch of different types of anemia. We have iron deficiency anemia, which is when we have inadequate iron intake. So if we're having inadequate iron intake, I would think it might be because they're not getting enough iron. They might be a chronic alcoholic or suffer from chronic alcoholism, and that can cause iron levels to be low. Malabsorptive syndromes like Crohn's disease, because that affects your body's ability to absorb iron. A partial gastrectomy or removing a part of your gut can affect how iron is absorbed. Pregnancy lowers iron levels, so you really, really must be careful with pregnant women, and that's why we always tell them in our patient teaching for pregnant women, hey, increase your iron intake because they're at risk for iron deficiency anemia. Being an adolescent, you're going through a bunch of changes and eating patterns might not be so great. And infections, okay? This is one of the more common anemias, but I just wanted to point out that these are some of the things that can cause it. But remember, it's iron deficiency anemia, which just means they don't have enough iron. So that means we're going to want to teach them about ways to increase their iron intake, such as intaking those red meats and things like that. Or they might be prescribed iron ferrous sulfate, which I'll get into in a little while. Next, we have vitamin B12 deficiency, another type of anemia that's also potentially dietary cause, and this one is specifically dietary cause, so they're not getting it in their food. It can also be caused from, just like in iron deficiency anemia, a partial gastrectomy or a removal of some part of the GI system, purpurineous anemia, or malabsorptive syndromes like Crohn's disease. So you can remember iron deficiency and vitamin B12 as a major cause of these types of anemias is a dietary deficiency. Next, we have one of the most problematic types of anemias is aplastic anemia. It's when the body stops producing enough new blood cells. So we get low WBC count, low RBC count, and low platelets. Just for reference, I listed the values of what's normal. So WBC normal is like 4,500 to 11,000. So if they have a white blood cell count of 3,000, not good. Normal red blood cell count, like I said, differs, but hematocrit is normally 36 to 48% for women and 41 to 50% for men. And hemoglobin is normally about 12 to 16 or 14 to 18 for men. So that's why in polycythemia vera, we were seeing how high hemoglobin and hematocrit levels were to cause that, whereas it is the opposite for aplastic anemia, everything is low. And in this, we also have platelets that are also low, and normal platelet count includes 150,000 to 450,000. Now, my main thing is that if we have aplastic anemia, I want you to focus on this word, neutropenic precautions, because they have low white blood cell count, low red blood cell count, and low platelets. So since they have those low WBCs, we want to educate them on things so that they can prevent infections, because these patients are highly at risk for infections because they don't have a high enough WBC count. So normal or NCLEX like things that you'll definitely see on your exam or come up is that neutropenic precautions are what these patients go on, and this includes no flowers in the room, no fresh fruits or vegetables, no visitors in the room, hand hygiene, and masks when they're leaving the room. Anytime they're going to leave the room or go somewhere else, they need to have masks. Even when people are in the room, the patient should be wearing a mask to protect themselves. So those are very important, those neutropenic precautions, especially for aplastic anemia patients. Assessment findings for anemia in general. Remember, we're talking about anemia means low red blood cell count. So they don't have enough red blood cell. We're thinking about, right, fatigue and pallor and cool skin. Because why? Because they don't have as much red blood cells, which means there's less circulating RBCs, so that's going to cause pallor and coolness of the skin. They're also going to have delayed capillary refill, which means greater than 3 seconds, because normal is less than 3 seconds. These patients can't really tolerate the cold. They're going to be fatigued because they don't have as much RBCs and they might have dyspnea on exertion. They're also going to have orthostatic hypotension or low blood pressure. Okay, so like I said, these are all the normal assessment findings. Think about it. Low red blood cell count, we're thinking about tachycardia and that compensatory mechanism for that orthostatic hypotension because of that decreased RBCs. Dyspnea and fatigue because of the low RBCs is making their body more fatigued because there's less perfusion. We have pallor, cool skin, malted skin, which is another fancy way that the NCLEX likes to describe anemia, and a delayed capillary refill or greater than 3 seconds. Treatment depends on the type, right? Because iron deficiency and vitamin B12 are caused by dietary. So we're going to increase iron supplements for iron deficiency, and we're going to increase B12 supplements or B12 like foods in their diet. All right, and steaks and meats actually have a lot of iron and a lot of B12. Aplastic anemia depends on the cause. So we're going to try to figure out why that's caused. Is it from chemotherapy, radiation, something like that? And give them appropriate blood transfusions. Nursing interventions, which I should have titled, but the next few bullets are nursing interventions. This includes monitoring their lab values, right? Those RBCs, hemoglobin, hematocrit. Think about it. Anemia or any type of anemia means a problem with the red blood cells. We want to encourage activity as tolerated because remember, they get easily fatigued. Encourage foods that are high in iron, meat, fish, poultry, potatoes, beans, seeds, tofu. All of these different types of foods are really high in iron. And we also want to encourage iron intake generally, not just for our iron deficiency anemia patients, but all anemic patients, because iron helps with increasing the hemoglobin because hemoglobin is made from iron. So if we increase iron, we increase hemoglobin, which helps increase RBCs and getting those RBCs flowing in the body, okay? We also want to administer O2 therapy as needed to help with that low SpO2 and promote tissue perfusion. Administer blood products depending on how low that hemoglobin and hematocrit is. We might need to give them a whole blood cell transfusion or a partial blood transfusion. It really just depends on the situation. And we also want to monitor skin integrity and making sure we move these patients, turn and rotate every 2 hours because they're at risk for ulcerations and pressure injuries because of the decreased perfusion. Now, something that I said that we can give our anemic patients is iron. So we have something called iron ferrous sulfate. So this is really important and highly asked by the NCLEX, and it'll probably be on your exam. So iron, things that we want to tell our patients who are taking iron supplements or iron ferrous sulfate, take 1 hour before meals or 2 hours post meals. No milk because it decreases absorption. No antacids because that also decreases absorption. So no milk, no antacids. If taken in a liquid form, rinse your mouth because these will stain your teeth. So make sure they rinse their mouth, okay? They should preferably drink it through a straw. Increase their iron intake through meat, fish, poultry, all the foods that we talked about. And making sure that they also take iron foods with a source of vitamin C like orange juice because this enhances the absorption of iron. Keep iron in a dark, cool place. Increase vitamin C because it, as I said, helps with the absorption of iron, like orange juice, commonly asked. Constipation is a problem with iron. So we want to increase their fiber intake through things like broccoli, berries, avocados, beans. And if the constipation gets really bad, we can give them Colace to help them go to the bathroom. Dark terry stools, normal. If the stool is really dark and weird colored, normal. If with irons, with patients who are taking these iron ferrous sulfate. So if they see that, they should not be alarmed and make sure this is out of reach from children, okay? The next thing is sickle cell anemia. So sickle cell anemia is a genetic hemoglobin disorder. It creates crest-shaped RBCs. So they're like sickle-celled RBCs. That's why they call it sickle cell anemia. Remember, it's a type of anemia, so we expect all those manifestations that we spoke about already. But it just causes something a little bit different here because this is an autosomal recessive inheritance, which means you have to get it from your parents, and both parents need to have it. So factors that affect a sickle cell crisis, very, very important. A lot of things because this patient is very sick and any changes can really affect them. So stress, dehydration, anesthesia, being exposed to hot or really cold or really hot temperatures, high altitudes like going up a mountain and hiking, alcohol, infections, hypoxia, all of these things can affect what we call a sickle cell crisis. This is when, right, a normal patient who has sickle cells going through their day, but if they start going through any of these things, stress, dehydration, they can go into a sickle cell crisis, which can be very painful for these patients, okay? Because the manifestations include severe pain and swelling, fever, jaundice from the RBC breakdown, organ failure, and the pain that they're getting is because it's a vaso-occlusive pain because of these sickling RBCs, okay? There's also an increase in clot formation, which also causes decreased tissue perfusion. So remember, the thing to remember with sickle cell is it's so incredibly painful, and any of these things can precipitate a sickle cell crisis, which is no bueno. And they always ask about factors that precipitate a sickle cell crisis. So we want to know these. You should know these, and they will probably be on your exam. So diagnostic tests include to see if this patient has hemoglobin S, because hemoglobin S, or that sickle-shaped red blood cell, is letting us know that they have sickle cell disease. And they can do this through an electrophoresis where they kind of take it, look at those cells, and it gives us an idea if they have the sickle cell cell or not, okay? Interventions, I want you to remember HOP or HOP. Hydration first, then oxygen, then pain. I know we get a lot of priority questions, so it's always good, I think, to write your notes in terms of priority, but if you can't, here is one. For anemia, hydration first, oxygen second, pain last, okay? We can get the hydration that helps with the sickling of the cells, really great. Then we give oxygen, because oxygen is needed to help with the perfusion, and then we treat the pain last. For interventions, we're going to teach our patient, like I said, to avoid extreme temperature changes, high altitudes, alcohol, stress, dehydration, things like that. We want them to know their triggers and get immunizations because infection is one of those things that can cause a sickle cell crisis. Have a good diet and wash your hands frequently. Now, things that we can give, because this is a very painful, very, very painful illness, we can give them morphine sulfate or hydromorphone, okay? Make sure they don't double up, and teach them how to use Narcan or Narloxone, which is the antidote for morphine. They should know what that is in case they have signs of, opioid toxicity like respiratory depression, sedation, constipation, urinary retention, nausea, vomiting, things like that from taking morphine or opioids. But the medication that is commonly asked about too is hydroxyurea. Hydroxyurea actually helps with reducing the sickling episodes and decreasing pain. And we want to inform our patients who are taking this about, hey, if you're taking any herbs or over-the-counter medications, please tell your provider. And always, like I said, with pregnant patients, be careful. But hydroxyurea is used to reduce the sickling episodes and decrease pain. It's a very commonly given medication, okay? So I would know that. The next thing we have that I saw in your notes is leukemia. Now, leukemia is a problem with the bone marrow. Bone marrow produces red blood cells, white blood cells, and platelets. So the bone marrow is suppressed, which means everything is low. So we have leukopenia, or low white blood cell count, anemia, low RBC count, and thrombocytopenia, or low platelet count. Doesn't that also sound like aplastic anemia? Yeah, because there's all of those blood cells are being dropped. So a lot of the manifestations and interventions are going to be similar. Now, I've never been personally tested on the different types of leukemia. I would know, though, that acute lymphoid leukemia is very common in children, ages 2 to 10. I would know that acute myelogenous leukemia, or AML, affects all ages, and that chronic lymphocytic leukemia is one of the more common forms, but I would personally not get too crazy into knowing all of the different types. I would just understand that leukemia means bone marrow suppression. So we have low blood cell, red blood cell, white blood cell, and platelet counts. Now think about it, like in that aplastic anemia, right? If we have low or bone marrow failure, we're going to have decreased RBCs, which means we have anemia, and anemia means we have weakness and pallor. We have decreased lymphocytes or white blood cells, which means we have immunosuppression, which means we have increased risk for infection and fevers. We have decreased platelets, which means we have increased risk for bleeding and decreased clotting ability, which means we could see things like petechiae, bruising, and purpura, which is like purple-ish red spots on the body, okay? All of those things that I just spoke about, the weakness, the pallor, the anemia, the immunosuppression, all of that is the manifestations of leukemia. Fever, recurrent infections, all of that is from the decreased WBCs. The pallor, fatigue, lethargy from the anemia caused from the decreased RBCs. Unusual bleeding, bruising from the low platelet count, nausea, vomiting. We could also have lymphadenopathy, which is swollen glands, and neutropenia. So they're also on neutropenic precautions, okay? A diagnosis is we're going to see all these changes to all of the red, white blood cells and platelets. They can also be elevated because remember, if they have an infection, they will be elevated. So there is an abnormal, there could be a normal white blood cell count, but normally the white blood cell count has a problem and it causes immunosuppression. Okay, so how would we manage this? Okay, well, like I said, this disease, we were mainly looking at the white blood cell count, all these lab values, and because it is a type of cancer, we can give chemotherapy. With chemotherapy, it also inhibits the production of all those blood cells, which means it further causes anemia and fatigue and pallor. It further causes bruising and bleeding. So it can cause bruising and gingival bleeding. It further causes fatigue because of that anemia they get. So all of the symptoms and signs, like signs and symptoms or side effects of chemotherapy are pretty much what you see as a side effects or symptoms of leukemia because it just further exacerbates them, right, or makes them worse. Patient education, put them on infection precautions, those neutropenic precautions, bleeding precautions, okay? So electric razors, no contact sports, okay? Be very careful. Always keep your shoes covered, things like that, okay? Nausea and vomiting. They could have ulcers in the mouth, and they could also lose hair from the chemotherapy. Neutropenia is something that they can have as a result of chemotherapy because of that suppression. So because of all that suppression of those WBCs, we also have neutropenia or a decreased neutrophil count, which neutrophils are one of those primary defense cells that have with destroying bacteria in blood. So we really, really need our neutrophils. So when we don't have enough of them, they're really at high risk for infections. So the ways to prevent it include hand hygiene, no sick people in the room, no fresh flowers, no fresh fruits or vegetables, monitor the temperatures very carefully, and put them on reverse isolation precautions, okay? Make sure they also have a mask if they're going to leave the room or anything. Also, like I said, manifestations of the chemotherapy or a part of this leukemia include thrombocytopenia, so they have an increased risk of bruising, petechiae, purpura, and bleeding, and anemia or increased fatigue, pallor, and shortness of breath. Nursing care basically is all of the things that we talked about: anemia, platelets, white blood cells, and how to treat all of them. So with anemia, we want to prevent bleeding, and even with that decreased platelet count, so we want to avoid contact sports are like really like physical things. Increase the RBC by Epigen. It's an RBC stimulant. We can give them an infusion of platelets. And remember, they're prone to bleeding, so we want them to have a soft bristled toothbrush as well. That's another bleeding precaution. And no alcohol containing mouthwashes because that can burn. So all of this is just a repeat. So overall, we want to watch their vital signs, take their temperature, strict intake and output, especially daily weights, see what's going on, especially with that chemotherapy. Assess the mucous membranes because they're at risk for ulcerations in the mouth or infections. Monitor levels of consciousness and behaviors because, chemotherapy and all that can lower everything so low that they might pass out. Pain assessments because we want to make them comfortable. No, this is really, really important. No live vaccines when someone's immunosuppressed, because actually those live vaccines can cause them to get that infection, and it can be really bad, especially when they're taking chemotherapy or if they have leukemia, okay? Now, the last thing I want to talk about is Hodgkin disease or Hodgkin's lymphoma versus non-Hodgkin's lymphoma. Now, it is a type of lymphoma. The thing that I would know is that this is unicentric, or it involves usually a single node. It's most common in men, but I would know this, that Sternberg cells are present because the manifestations in Hodgkin's and non-Hodgkin's, which is a problem with the lymphs, we're going to have lymph node enlargement or lymphadenopathy, pruritus, maybe fever, sweats, things like that. And even the management is going to be very similar. But what lets me know that, hey, this patient has Hodgkin's disease or non-Hodgkin's disease is the presence of these Reed-Sternberg cells, which is very commonly asked in the NCLEX. So if we have Reed-Sternberg cells, that means we have Hodgkin's lymphoma. If we don't have these Reed-Sternberg cells, we have non-Hodgkin's lymphoma. Okay, this is a type of lymphoma where the lymph node tissues become infiltrated with these really malignant cells, and it's very, very rare. But compared to Hodgkin's, right, Hodgkin's is a little bit more higher cure rate, okay? But non-Hodgkin's, not so good. It increases with age. Like I said, manifestations very similar. Lymphadenopathy or increased lymph nodes and swelling of that. We may treat them with chemotherapy the same way that we might do in Hodgkin's, but the real difference between these two is that Hodgkin's has Reed-Sternberg cells and the other one doesn't.